this slide. We've seen it enough, I think, but so, oh, it's okay. So I think all of those factors that were on that last slide lead us to cultural adaptation work, which for those of you who are unfamiliar, cultural adaptation is the modification of interventions to consider things like language or culture or context to make them more compatible with the target group's culture. So in this situation, it's Black women who use substances. Adaptations can be surface level, which you could imagine that as like modifying the names of individuals in a role play in a behavioral intervention, or you could think of them as more deep structural changes, which are things like including like cultural ceremonies or adding cultural values to an intervention. And adaptation actually has the potential to increase efficacy and sustainability of interventions. So that leads me to my work adapting over the last since like 2006, adapting this intervention called Safer Sex Skills Building, or SSSB for short. SSSB was a trial that was included in NIDA's clinical trial network, which has been a really great home for me, data-wise and just support-wise with mentorship. And it was an HIV prevention intervention for women who use substances. It's delivered in group format. So you can imagine 5 weekly groups, about 60 to 90 minutes, that are offered in substance use treatment settings. And each group covers topics such as HIV testing and counseling, triggers for HIV risk behavior, safer sex negotiation, condom use practices. And in the trial for the NIDA Clinical Trials Network, they saw a decrease in HIV risk for all women who were in the trial, which is great news. But there was still a really high level of HIV risk behavior for Black women at the end of the trial. So that was kind of a sign for our team that it may not be working as well for that population. So we set out to culturally adapt it. And this could be a huge presentation, but I only have a couple minutes. So if you have questions on how to do this, please let me know. But we used an adapted form of what's called a Delphi process. And some of you might be familiar with the ADAPT-IT model. We use some techniques in that as well. And we created what we call, which is not a great name, SSSB Culturally Adapted. And it included a lot of changes. So it's more interactive learning and less didactic. It has a really cool condom demonstration video that was filmed by a Black psychologist, Black female psychologist. There's inclusion of sessions around gender roles in the Black community and an increased focus on negotiation of safer sex, specifically given the power dynamics at that intersection of race and gender and substance use stigma. There were culturally relevant barriers related to condom use that were discussed. And we were informed that, domestic violence was also a thing that women in this population were really focused on when it comes to sexual risk negotiations. We included that. And then my favorite part is there's this really beautiful cultural closing ceremony where women talk about things that empower them and how that they can keep themselves safe to support their community, which is lovely. And we did a small initial test of SSSB culturally adapted with a 6-week follow-up, comparing it to the original version. And at baseline, we found that very few participants were reporting condom use in their last casual sexual occasion. But at follow-up, more women in the culturally adapted version versus the generic version actually reported condom use during that last sexual occasion. So that's good news. It shows maybe promising results that need to be tested in RCT, obviously. But one thing that we did notice is that when we were doing the cultural adaptation, we realized that we just weren't getting the voices of the women themselves. And that led us to go into a community engagement space. We actually were approached by a community. At this time, I was working in Cincinnati, Ohio, which is where I trained. And the community was a low-income, predominantly Black community that had seen some of our work in SSSB and really expressed that they needed some sexual health services for Black girls in their community, and they didn't really know what to do. And so this is awesome because this is a community-driven research project, which really rarely happens. But we decided to adapt the SSSB culturally adapted version a second time and make it more appropriate for young Black girls and their moms. And this is one of my things I'm most proud about in my career so far. We developed a model for cultural adaptation and community collaboration that uses community-based participatory research principles. And we published it with the community members. So the last 2 authors on that paper there that you see are community members, which is lovely. So the next step obviously is an RCT for SSSB culturally adapted. But maybe this is not the right way to do it, but I saw that there were a lot of limitations in SSB culturally adapted. One is that it was developed in the really early 2000s, so it doesn't have any of the innovation for HIV prevention and treatment that we have now. It doesn't have anything about PrEP. It doesn't have anything about U equals U, none of that. It doesn't give any consideration to intersecting identities, which I think is really important for HIV prevention. And I'm seeing, working in a lot of substance use treatment settings, that there's a change in the landscape of who gets access to treatment now and who doesn't. So it's far less common to see Black women in large groups in the same substance use treatment settings. At least that's kind of been my experience. So that led me to think of my idea for the K23, which instead of doing the RCT for SSSB-CA, which also would be really hard in a K, is to make it into a new iteration, which I'm kind of calling the technology-based SSSB cultural adaptation. So this is what I'll be doing partially in the K, is designing a technology-based HIV prevention intervention for Black women in SUD treatment. I'm going to be using the same CVPR principles. In the tech world, they call it participatory design, but it's kind of the same thing. I'm going to modernize SSSB culturally adapted. I'm going to add an intersectional lens to it and adapt the delivery method to include technology. And then I'm going to do a theater test, which is a traditional cultural adaptation approach to test the intervention and receive preliminary feedback on feasibility and acceptability. Bless you. So just to give you a little bit of an idea of how I think this will look, the original SSSB-CA had those weekly modules that were delivered in person in in-person groups. I think all of those could be moved over to more of a Zoom format, video conferencing. And obviously they'll be modernized to include some of the new innovations we have in HIV prevention. So there might be core modules in HIV and STI information, condom use practice, negotiating safer sex, which are all included in the intervention now. But what I think is going to be really cool moving into a tech space is that we have the opportunity to further individualize the intervention with these 10 to 15 minute sort of homework assignments. I might not call it that because people don't like that term, but that are completed via a mobile app. And the mobile app is going to be really cool because it'll use a technique called collaborative filtering to really individualize the materials that people are getting related to education or resources. So for example, if someone does the video session on HIV and STI information, but they identify someone in the LGBTQIA+ community, they may get further information in their homework assignment about HIV prevention specifically for that community. And you can see the other examples there too. But the caveat I have at the bottom is that these are just my ideas, but I'm working right now to build a CAB of 5 to 10 Black women who have a history of substance use treatment, who I'm going to be working with throughout this whole process. So if you have any patients, please let me know. They will be paid for their time. And that's it. So I am in the beginning phases of building the CAB. I am learning a little bit more about the intersecting factors that impact HIV prevention. And I'd love to come back and tell you more about the K when I'm further along. I think we're going to do a couple questions, right? Oh, yeah.
That's really great, Carmela. Is this on? Okay. So this is just a stellar example of really community engaged research. It's really particular research. And what are some of the things that you found most surprising? Most surprising insights that came from actually listening to stories from the women in the group that you really wouldn't have even thought about had you not included it.
Yeah. So what are the most kind of surprising things that I learned working with the community? One of the things that comes to mind, it's a great question, and is actually my dissertation project. I had a totally different idea planned. But what I learned through one of the iterations of culturally adapting the intervention is we were hearing a lot about transactional sex, or what I thought was transactional sex. And so the women were basically saying they don't have any interventions or any education about how to manage transactional sex in their community. And so I went to the literature to start trying to figure out how to define it, and if there's any interventions. And the definition in basically the academic community didn't know how to define it. Like people were calling economically motivated sex. There were all these different, there's international components to it. And so I brought that back to the community to say, like, I don't even know what you guys are talking about because I can't find an intervention for it. And they just kind of were like, oh, we can define it right now for you. And they just like, boom, boom, boom. It's all of these different aspects. And so it's just a good message of, sometimes academics, we want to write and talk about things that our community just knows right away. So that was a good lesson.
So much for talking about this. I think this work is really important, and I'm about to show some slides about PrEP use movement across the U.S. But I've been working with some colleagues in Alabama, Boston. But I think the main message coming from that is that there's a gap way at the beginning about education or about in knowledge of Black women's team, knowing that this is an intervention. And so I'm just curious if you have come upon that in any of your formative books so far, and what your plans are to kind of elucidate that so you incorporate into technology.
Yeah, thank you. So the question is about knowledge of PrEP use for Black women who use substances. I have another grant right now that is looking at technology access in substance use treatment programs. And I've looked at it, the results by race, but not by race and gender yet. But by and large, even in those communities, and this is here in San Francisco, PrEP knowledge is really low. Which is really hard for me to hear because people in substance use treatment would be such a good population to know about PrEP. But when we were working with the community, things such as PrEP, I was constantly telling people about it for the first time. Even things such as, such as HPV, I was telling people about it for the first time. So I do think that it's going to be a lot of just kind of education. Those medications are out there and how to advocate for them with your doctor or bring them up with your doctor to talk about. Yeah, I think we have to go to the intro, but I can touch base with you. Oh, okay. Thank you.
Build on the community engagement piece, the dissemination. I know you're just getting started.
Yeah.
But do you have a sense as to how to go about that in ways that are meaningful and scalable? Is that
Yeah, dissemination. So I have written into the K that my next step will be an implementation science kind of training. And so I would love to kind of focus on implementation effectiveness trial. From the beginning, I'm working to make sure this intervention can be fully integrated into substance use treatment programs. Because I work clinically in those programs, I know that, we don't use EBTs because they don't work for us. So that's my first step, is making sure that I design it from the ground up for dissemination. Yeah, thank you. Okay, great. It's my pleasure then to transition to introductions. I'd like to introduce Dr. Renee Heffron, who's the professor of medicine at University of Alabama at Birmingham. And Dr. Heffron is an applied clinical epidemiologist and HIV prevention researcher with experience that incorporates design and execution of clinical trials, implementation science, behavioral science, and qualitative research. She leads numerous research projects focused on biomedical HIV prevention using pre-exposure prophylaxis, including studies of novel products and optimizing delivery of efficacious products with close collaborations in Uganda, Kenya, and South Africa. She's also the director of the Center for AIDS the Center for AIDS Research at UAB, a center with 35-year history of supporting HIV across disciplines of basic, clinical, implementation, and community sciences. And through her career, she has been a mentor to dozens of trainees, including doctoral students, fellows, and early career investigators in US and African institutions. So thank you so much. I'm looking forward to your presentation.
Great. Well, hi, everyone. It's a real pleasure to be here today, and thanks to all of you for staying and listening and asking questions. We're done at 10:30, right? Okay, so I'm gonna make sure I leave about 5 or 10 minutes for questions. And so just a couple of disclosures to start. But here's just what I wanted to do is I'm an epidemiologist by training, so just a quick update to put us on the same page about HIV incidence, and then talk about what I call first generation pre-exposure prophylaxis. and what we've learned from that so far. And then give you a snapshot of where we are with next generation products that have demonstrated efficacy, and talk a bit about new products in development. But then I want to end by talking about some scientific challenges that we have as we have success. And I'll start with the end. What you're going to see, and I hope that we can discuss, is that we have daily oral PrEP, and that's afforded us lots of opportunities to learn about how people use it and how new PrEP products may or may not actually increase HIV prevention coverage. I'm really truly an optimist, and so I believe, and we've seen in other fields, that increasing options for HIV prevention will yield an opportunity to welcome. So as we increase options for HIV prevention, this will yield an opportunity to choose and switch between methods, which should result in greater coverage for more people at more times when they may be exposed to HIV. But our scientific methods and our capitalist tendencies easily leave behind groups of people who are most in need of prevention options. And if we're not intentional about their inclusion, we're going to continue to fail here. And then with success, we create these scientific challenges, and I'm going to talk specifically about comparator groups and how do we do this in today's world. And we're going to need to innovate dramatically in order to overcome them. So just to bring us on the same page, this is HIV prevalence among adults around the globe, still really high prevalence in sub-Saharan Africa, even in Eastern Africa, and but globally, everywhere, we're facing this challenge. If we look at new infections, we have seen a decline, and this is really tremendous. If you see, we saw, when we had global ART access with combination regimens really start, we saw a decline there. When we had proof of concept of antiretrovirals for prevention, that continued the decline. And then our first label indication for tenofovir as PrEP in 2012, this is all really been fueling this decline, but we're failing the global targets that were set. Whoops. Today, we have more than 6.7 million people who've initiated PrEP around the globe. And so the numbers are really growing. This is primarily daily oral PrEP. But I would be remiss up here as the director of the UAB CFAR without drawing your attention to the South part of the US, which experiences the largest burden of new HIV diagnoses in the US. And if you can kind of overlay these two maps, this is the rates of people using PrEP with 2022 data. And in those places that have the highest incidence, we don't have enough PrEP use. There's not enough coverage to meet the incidence that we're seeing and actually have a population level effect. And so let's turn to what we know and what we've been learning about oral PrEP. Really important, this slide is old, but I've been showing it for a while. It's important to understand the daily oral PrEP that we have with emtricitabine tenofovir, what it was. When we first started testing it, we knew that it was a potent agent with broad activity and rapidly active. We knew it was safe. We had data from lots of use in treatment. And so we knew it was safe. We knew it was easy to take with low pill burden, no food restrictions, few drug interactions. We knew that it was plausible from a prevention perspective that it would work for prevention. We had efficacy in primate models. We had use of it in prevention of mother-to-child transmission, and it was accessible, which is different than everything else today, because it was there and approved for treatment. And so it was accessible, it was on the shelf, and could be also used for prevention once we had efficacy. This was, these data were sort of unfolding when I was a doctoral student and a postdoc. And, it took us, of these six placebo-controlled efficacy trials plus 2 active comparator-controlled trials. It took us a long time to kind of unpack these data with differing efficacy results and different levels of adherence, but really to come to the conclusion that PrEP will work if you take it. And very interestingly, I think as an epidemiologist, were these data of efficacy versus effectiveness. Normally when we do placebo-controlled efficacy trials, that is, we assume that will be in that controlled setting, the highest level of efficacy that we could possibly see. with this prevention medication, when we knew that there was efficacy and we could talk to people about the efficacy and about the importance of adherence, we actually started to see that people who were using it obtained higher levels of effectiveness, and that's what we're seeing in the efficacy trials. And on the left are the data from serodifferent couples comparing the efficacy trials to effectiveness demonstration project. And on the right are the trials in men who have sex with men, with 44% efficacy in IPREX, but then 86% when in the UK PROUD study, which was an effectiveness trial. So this is very interesting from a research and a prevention perspective of how do people take prevention, and it's, I think, very different from the treatment landscape. I put this slide in just to show you sort of my career trajectory and how it's overlaid a bit with the development of PrEP for prevention. So in the middle section, early when I was a student, we were doing efficacy and safety studies, and I was involved as a data manager in the clinical trials. We had an FDA approval in 2012, followed by WHO guidelines. And at that point for oral PrEP, we went into this area of demonstration projects and open label studies. And I really shifted focus to doing behavioral science and understanding factors that led people to use PrEP, and then implementation science. And how do we really optimize delivery of PrEP? And I'm going to show you a bit of data now for some of those studies we've been doing. So the first study is in Uganda in collaboration with Andrew Mujigira and his clinical research site on the outskirts of Kampala. And this was a study with serodifferent couples designed in 2015, funded shortly after, launched at a time when PrEP was very new to Uganda, and couples were not, there were no PEPFAR indicators for couples. So we sort of had this unique moment in time when we could do this study. And we conducted a step wedge trial, which this is the study design for a step wedge trial. So we worked across 12 ART clinics across the city and collected baseline data for the first 6 months or so on viral suppression in the partners living with HIV, and viral suppression was our main outcome. And then over time, we introduced PrEP with a very experienced PrEP research team that would conduct training on how to deliver PrEP and how to monitor for side effects and how to counsel on adherence, and actually provided PrEP commodities and HIV test kits for the HIV negative partners. And so we would do this for 4 facilities at a time, and then continue the whole time to collect data through their national lab system on viral loads. And so over time, eventually all of the clinics rolled into delivering PrEP specifically to the negative partners in these serodifferent couples. And we were able to add in research procedures with some of them to do tenofovir levels in the negative partners, and also collect data to help us cost out the cost of this. And so I'll show you this slide, which is just looking at PrEP discontinuation, really tried here to use public clinic level data. So these are from logs of people initiating PrEP. And remember, these are serodifferent couples. So the message was that PrEP is a great thing while your partner is starting ART and getting used to it and learning how to sustain use, but you may not need it after 6 months or so. Once we've seen either a viral load decline or we know that they've sustained ART use. And so you see, in this, the way this was designed, everybody who started was in the study, and we followed quite carefully. There's a big drop off at the first month, but then those people stay on pretty well and then start to drop off around month 3 or 4, which is what you would expect in this population. Now, one of the main research questions for that study was, when you're adding PrEP into this already very busy ART clinic, are you going to mess up the ART use and the ability of clinicians, or the time that people have to counsel on ART adherence? And so the answer to that was thankfully no. And we in fact saw, during the control periods, 82%, and during the intervention period, 77% of people were virally suppressed, which was not a statistical difference and was reassuring to everyone that this could work. So then the next study I want to talk to you about is one that we did in Kenya, which we recently presented at CROI. And this was done with my colleague Nellie Mugo. And Nellie and I had been interested in working in post-abortion clinics for some time. These are in Kenya, like many places, abortion is illegal, but there are post-abortion clinics for people who have an emergency or a complication from an abortion. And so we thought, you know, people coming in for these services are at high risk of continuing to have condomless sex. Oftentimes they get pregnant again. And so perhaps this is a population and this is an access point where we can get people who really have a need and an indication for PrEP. And so we designed, this was both a programmatic cohort, similar to the last study. And with this one, we embedded a cluster randomized trial to try and see if we could do something simple to improve adherence and persistence. And these are two students that worked on the project, and one did her PhD out of it and one did her MPH out of it. Just looking at the data, we worked with 14 public and private post-abortion clinics across central and western Kenya. And we were able to abstract data from over 8,000 women seeking the service during about a 2-year period. You know, many were counseled for PrEP, which in this case, counseling was really learning about it for the first time. And so then many of them elected to have an HIV test. Most were negative. There's a big drop off in those who actually initiated PrEP. And then the continuation is pretty small. The top reasons for declining PrEP in this cohort is that they told us, I'm in a stable relationship and so I don't need PrEP. And that's, you know, that was what they reported to us. There's lots to think about there. But then these were we also, once every clinic was stably providing PrEP, we randomized them to where half of them did a pretty simple phone call intervention where they had a schedule and a script to call people and remind them about their appointments, but really talk with them about their experience after 4 days on PrEP, after 2 weeks on PrEP, after a month on PrEP, and try and offer some support for them. And you know, these are the outcomes looking by arm here. And the thing to notice is, so where the purple is where the trial started, and in black is everybody who entered the cohort during that time. And in the like pink are people who came back for month 1. And so there's a little separation there across arms, but the main point is that this return was pretty poor. And I think we were not totally surprised. This is a population in a place that people don't want to come back to. And it's not, a post-abortion care is not a continuous service. So the question really here is, you know, how do you link these people to a place that is for follow-on care, which would be the family planning clinic. But triangulating all of that data in these health systems is a real challenge, and something that we're going to continue to work on and do, but that's kind of what we learned from this. And then the third thing, switching gears completely again, is back in Uganda with my colleague Andrew, where the Ministry of Health actually knew about our work in PrEP delivery and came and said, you know, there's this RFA to work with people who use drugs, and we've just started the first methadone clinic. So can you help us to integrate PrEP into this harm reduction service? And so we said, okay. And not only did we do it into a couple of pictures, the methadone clinic on the left, but also worked with a tremendous community-based organization that does needle and syringe exchange. And this is some of the study team visiting with some of the people in the place where they do HIV testing and talk about PrEP and lots of prevention. And so what we're doing in this study is, first we collected formative research and really spent time as a team learning about how to work with this population. It's very new to Andrew and myself and his team, but it's a wonderful team who's really been open to working with all kinds of populations. And they're working, this is Uganda, we're working with men who have sex with men, transgender women, people who inject drugs. I mean, Andrew's team is really just so tremendous and innovative and open. And so we did a formative research, both to give us time, I think, to learn and train, but also really just to talk with people using drugs and what would they want about HIV prevention and how should we integrate it. And so, you know, we learned a lot from them, specifically particularly about integrating PrEP, but not changing the harm reduction services available to them, making sure that their priority would be met. And then also tons about stigma from healthcare providers, stigma in the community, and how to really integrate services in a way that wouldn't create more stigma. And so this is what one of these participants told us. I would suffer from different diseases and fear to go to a healthcare center, yet here, which is in the with the community program, they know who I am, my situation, and what I use, which you do not find in other hospitals. So really, you know, this community program was really important. And these are just some early data from that study. On the left columns is the methadone clinic, and on the right is the needle and syringe program. And I've been trying to look more about, there's lots of ways to measure persistence on PrEP. So these are refill data. And this is a way of looking at it where we're not concerned with what schedule you were given per se, but we're concerned with how many pills you got. And in this daily dosing regimen, when did you come back? And so if you look at the needle and syringe program on the right, when people got 30 pills, 76% of them came back within 30 days. And when they got 60 pills, 84% of them came back within 60 days. And when they got 90 pills, 50% of them came back within 90 days, which to me shows, you know, really consistent engagement and wanting this. In the methadone clinic, it's a lot less. And we're, you know, and knowing the settings and the way that people, I'm not surprised by this. The community setting is very going to people where they are. The methadone clinic is a tremendous first program of its kind in Uganda, but it's heavily guarded and it's not the most welcoming place. So I've also done some work just to summarize. We've learned so much about daily oral PrEP, from a lot of different studies. And I just have a quick summary looking kind of in this concentric way of looking from the individual level out to the policy level. And I won't go through everything, but I think key takeaway points that we've learned is at the individual level, we need to normalize discontinuation and restart. That's part of it. We also need to value the non-HIV benefits from it. And that's things like sexual pleasure and conversations about it. And also STI testing that goes along with it in some settings. And we need to exclude fewer people. You know, in the clinical trials, pregnant women were excluded. In many of the trials, transgender people were excluded. And the label indications feature that. And it's very problematic for these groups that have the highest incidence rates. From an interpersonal level, I think we need to really cultivate social support and combat stigma. And there's tons of work being done on how to do that, but it's different in across the globe and different populations. From a community perspective, we're doing better, I think, at centering community, but we have lots more to do. And certainly your work, Carvella, is really amplifying this, how to do it. We need PrEP champions, and they come in all forms. And we need fresh and modern messaging. From an organizational perspective, I think we need to increase access points. And we're starting to see that pharmacy delivery, mobile van delivery, all kinds of things to bring it out, because it is a very safe and fairly simple medication to do. And then from a policy perspective, demedicalizing, making it affordable and creating inclusive policy. And we've seen that, you know, play out in Kenya. The initial PrEP guidance was at anybody at risk, whereas in South Africa, the initial guidance for PrEP was for people engaged in transactional sex. And that created all kinds of stigmas and problems, and the rollout in South Africa was slower. So let me turn to a few slides about next generation products. And the monthly vaginal ring for HIV prevention we've had data on this efficacy now since 2016. 2 placebo-controlled randomized trials had very similar results, efficacious at 27 or 30, you know, about 30% efficacious. So definitely not what we see with daily oral PrEP. That was sufficient for approvals and positive opinions from the European Medical Association, approval in South Africa and Kenya, Uganda, many many countries now. And ad hoc analyses that look at how much dapivirine is eluted from the ring show that if you have the target release, so the most release, probably which would be correlated with the highest levels of adherence, you may achieve an effectiveness of 75% or so. These are modeled data, so unknown. So, but efficacy is there, but not to the level with daily oral PrEP. And that's something we're really unpacking with. How do you counsel about this product? The REACH trial, I thought, had very interesting results, which was a crossover design. So in the first period, people were randomized to either oral PrEP or the monthly ring. And in the second 6 months, they switched to the other method. And in the third 6 months, they got to choose. And if you look at the adherence levels during randomized periods, and then in the choice periods, people had about the same levels of adherence. Interestingly, during the choice period, more than half of the participants chose the ring, which I think is really interesting. And I think we're going to be seeing a lot more data to inform us about choice and also about switching between methods over time. Here's a look, just a quick look, some initiation starting, but very few. And then injectable cabotegravir, which is a 2-monthly injectable, has really been tremendous. And in these two parallel trials that happened, both trials were stopped early due to tremendous levels of efficacy. Both were, the comparator for both groups was oral PrEP, which was different in sort of the first trials like this. And so we're learning about how to conduct these trials and what we can gain from them. Cabotegravir was approved for prevention in late 2021. And here's a look at how we're doing. Some access in the US, Brazil just got some, a little bit in South Africa and Zambia, but lots to learn about this. And again, how people view the burden of coming back every 2 months to a clinic, and how they do with injections. So we're building a situation with options, which I think is very exciting and will ultimately lead to greater HIV prevention coverage. And I've been doing some work with students about, how do we expand coverage? How do we learn from oral PrEP programs and integrate? And this slide is particular to the cabotegravir injections, and really finding some interesting findings. So in this balance of how do you target the product? Well, some people think that you should prioritize CAB rollout only for key populations, whereas others think it should be, targeted to everybody. Some feel like CAB should be positioned as a PrEP option by emphasizing the importance of all of its attributes, including its efficacy, whereas others think that the efficacy should be emphasized first. And then in terms of availability, well, do you wait for the product to actually be available? Some people have felt like, no, you should wait till it's available, because if you prime the community first and then it's a long time, the community sort of loses faith that it's coming. Whereas other people think, no, you need to generate interest and we need to start now so that we're ready. So there's lots of things to consider. There's a few new products I just want to highlight. Lenacapavir, Monica mentioned, it's available for treatment. It's also being studied for prevention. And Gilead is developing this, and they're doing it in a few different ways. I mean, they have their big efficacy trials in cisgender women, also a trial in men who have sex with men, transgender women, men, and gender non-binary folks. And then they have a separate study in women and a separate study in people who use drugs, which are not efficacy studies, but are looking at PK safety and acceptability, so that these data can all potentially, if it's good, go off to the FDA together, and hopefully we won't have label indication restrictions like we have for other products. And then there's MK-8527, which Merck is developing, which Monica mentioned islatravir. This is sort of, this is of the same class, and it's also which is a brand new class of antiretrovirals, and is just in phase 2 studies that are, I think, mostly enrolled in the US, South Africa, and Israel. And this is being formulated for prevention as a monthly pill. And so we'll see. The phase 2 studies are also going to guide the levels to test in potential efficacy studies. So those are coming. And then I also am on the outskirts, but involved in the Matrix project, which is a huge study or a huge project funded by USAID to develop new products specifically for prevention for women. And there are a number of things. These are in preclinical phases, most of them, formulation, some of them, but there are fast dissolving vaginal inserts, vaginal films, and then combination pregnancy prevention and HIV prevention, a ring and a film. And there are others coming through this Matrix product pipeline. So there are lots of things being developed that we will continue to see. But so the question becomes, how do you do this? Because now that we have oral PrEP and it's widely available, it's no longer ethical to use a placebo as a comparator. And so what can you do? Well, the studies of cabotegravir used oral PrEP, but now we have cabotegravir approved and rolling out, slow as it is, but how does this factor in, especially for trials that haven't been designed yet? And the other thing that strikes me is if you're using oral PrEP, you're sort of hoping for non-compliance in the comparator arm, or you're hoping for the same levels of compliance that we see, and that's kind of weird. And so one thing that people have been talking about is, can we, like in a contemporaneous cohort or something, measure incidence? And I'll show you, we just recently tried to do this. And so with Connie Kellum and Deborah Donnell and Irene Mukui, we led the Insight cohort recently, which was a prospective cohort with open label offer of oral PrEP with 6 months of follow-up in 20 sites in East and Southern Africa. And the women who were, women were recruited for an open label PrEP trial, and those who screened positive for HIV, we then collected other samples and did recency testing to determine if their infection was within the last 2 years or not. And you can use those data to do calculations of baseline or background incidence in the population. So we did, in that study, this was that cross-sectional HIV incidence using the RITA assay. We also did some interesting calculations using self-reported data from people when they screened, were they recently tested and were they positive, to try and look at an exploratory way. And then we had the observed cohort of people who were negative when we followed for 6 months. And so in doing that, with that recency testing, we had 7 people through this algorithm who ended up having a recent infection, which would give us an estimated incidence of 0.7 with this confidence, fairly wide confidence bound, which is pretty low. And in these settings that women were coming from, we think it's too low to be accurate. And so the different measures of incidence were 0.7 to 2.0 in the using self-reported data, and then 1.2 in the cohort that we followed over time through the traditional measurement. And so we've been thinking about this and why are we getting these various results? And one thing is that this was a study that was launched really fast and recruitment happened really fast. And so we're not sure that we recruited in the right way and had the right messaging in the recruitment. The recruitment was, come for an HIV prevention study rather than come for a study. We have options for people with HIV and without HIV, or something to really make it more welcoming to people with HIV. There's also concern about the assay because the assay was developed 10 years ago, and now ART test and treat is fairly universal in these populations. And so the assay doesn't work as well is not as accurate with ART. So lots of thoughts about whether this is a viable option. We will see and we will learn. The Gilead trial of lenacapavir is also doing it with far more resources and far more time and far more thinking. So we'll see what we learn from that. So just to bring us back to my points, I think we're growing a toolbox of medical options for HIV prevention. And at the same time, we're learning a lot from oral PrEP. It's giving us great opportunities. I think that as we increase options, which I think standing up here in 5 or 10 years, we'll have a proper toolbox with all kinds of formulations and modes of use and things. And so I think that we're going to get greater coverage. We need a lot of coverage and a lot of people though with PrEP in order to see population level incidence impact on incidence. And I do think we're starting to do better to include some of the marginalized populations that we don't often include in research. And I hope that that continues and we learn and we grow that. And then finally with success, I think we find new scientific challenges like comparator groups for these trials, and we'll overcome them, but we're going to need to work together and really innovate. So that's all. I think we have a couple minutes for questions. Yeah.
Okay, that was really great, Renee. I guess I have, I mean, that was pointing this out to me, but I have this question, like two questions. One is that when, you know, TDF-FTC was studied in IPREX, the efficacy was 44%. It's only good if you take it. And when the FDA was approached for the dapivirine vaginal ring, they declined it in the US, though it was passed in Europe and WHO. So it's not like that's so much, I mean, that's the same number.
Right.
It's just that you have to put it in. And then a related question to that is the real world data coming out for vaginal ring, because you're right, there's this, you know, we think of drugs doing better in clinical trials and worse afterwards, but that's totally the opposite.
Mm-hmm. Right. So to your first point, so the data that went to the FDA for Truvada, there were multiple. And so they had the 44%, but they had 75% from Partners PrEP as well. And I think that is what, you know, whereas for dapivirine ring, they had 27 and 31. So I think that's a different calculus for that, for sure. And then, yeah, I think what we learn about the dapivirine ring is going to be so interesting and important, because in the places where they have approved it, the thinking is like, okay, well, oral PrEP is not working for some people. We have a real problem with incidence in young women, and for so many reasons, daily oral PrEP doesn't work from them. Their partners find it. They live with their parents. They don't want to show their parents. They travel to school. They can't get to the clinic to get refills. All these things, and a ring, which is more discreet, can be, you know, it's not taken. It's not used every day. You insert it once a month. Maybe it's got lower efficacy, but daily oral PrEP not taken has zero efficacy. So, you know, maybe that's a better option.
Hi, Renee. Wonderful presentations. Just a couple of quick questions. You know, these PrEP persistence. And I was curious to hear what are some of the interventions that you have heard about or you're using for PrEP persistence, because it's a patient as well as this question I have is, you know, we really don't have much real world experience of scaling up along with ART, HIV incidence. There's only two places. That's you know, London as well as New South Wales. And both are fairly large populations of medical. What are your thoughts of whether or not we're actually with some of the newer innovations that are we actually to a point where we might be able to scale up as well as ART in more diverse populations?
Yeah, thanks, Greg. So actually, I think your questions kind of go hand in hand in some ways, because I think some of the innovations that we're seeing sort of in the East Africa, Southern Africa region are all about reducing complexity. So when you can bring PrEP to people, when you can deliver it at their community pharmacy or at a pharmacy or in a mobile van that stops at a community library or at a school, you know, a meeting place, then you can see higher levels of persistence. You've removed this barrier of needing time off of work and needing to travel and pay for travel and things like that. And so if you can do that, that's great. However, for CAB and lenacapavir, which are going to be new, I mean, we've only gotten to this with oral PrEP because we've been doing it for so long and we have confidence in, you know, the safety of it. And for the new products, we won't have that confidence, I think, from the beginning. We may build it, but we're gonna need to figure out what kind of level of provider can provide it, and can you put those people in these community settings? We won't know until we have done more implementation delivery science to try it out. So, and then going back to what Caravella was saying, I worry about, like the Black women in the South who don't know about PrEP, and many other populations who never seen PrEP as something for them, and no huge myriad of options is going to fix that problem. So that's another thing we have to think about and do better.
It's a question I struggle with quite a bit. I recognize that all that involved in the treatment involves long standing. But unfortunately, we're not in an ideal world. Our budgets are flat, especially when it comes from a funding standpoint. Since we believe in treatment is prevention, right? Fixed budgets. How would you advise someone on long-acting versus oral versus ring versus AR? Where would you prioritize?
Yeah. So Sunil's asking, how do you prioritize in a world with fixed budgets? I don't think I want to answer that. I don't think we can answer that yet. I don't think we should answer that yet, because we don't know what people need and what the uptake is going to be. I think we will be able to smartly answer that once we have some situations, and maybe they're in less real world settings or more controlled, where we can actually give people choice and see what happens. See how much switching needs, see how much they need to switch, and they need actually through their lifetime, they need multiple options. See how much. So if that's okay with you, so I would say let's not try to do that yet. Let's try to develop more things and then learn from that what works for people before we make decisions about that.
Okay, thank you so much. That was a great talk.